Hi, good morning. Assalamualaikum, colleagues and friends. It's my pleasure to introduce our speaker for today's CME session, Dr. Ngan Shan. Dr. Lai is a hematopathologist with a special interest in both adults and pediatric hemato-oncology. She obtained her master's in pathology in 2022, with subsequently served as a specialist at Sarawak General Hospital. During her tenure there, she played a key role in establishing new diagnostic service, including flow cytometry for leukemia, lymphoma, and myeloma. So she also helped with BCR-ABL quantification for chronic myeloid leukemia. So in 2024, she joined the Department of Pathology at University Malaya, where she continues to advance hemato-oncology diagnostic. Her current research focuses on measurable residual disease, particularly with T-cell acute lymphoblastic leukemia using flow cytometry-based approach. So today she will be speaking on measurable residual disease in leukemia. Small numbers, big decision is a critical determinant of treatment response and relapse risk in leukemia. So this session will also highlight the implementation of our hospital's flow cytometry-based MRD service, enabling detection of residual leukemic cells beyond the limits of conventional microscopy and strengthening our position in clinical decision-making. So please join me in welcoming Dr. Lai.
Thank you, Dr. Ma, for the kind introduction. So good morning again to everyone. Measurable residual disease, or some people like to call it minimal residual disease, MRD, for B-cell ALL has been available officially in our department since 2025. So today I'm going to talk about what is MRD, why we need to detect MRD, and how our lab is doing the MRD detection. So this is a bone marrow aspirate picture of a case of acute lymphoblastic leukemia at diagnosis. So at diagnosis, the things will be quite straightforward because the marrow will consist mainly the lymphoblasts. The rest of the hematopoietic elements are either not there or very much reduced. So after we got the diagnosis confirmed, it's a leukemia case, chemotherapy will be commenced and patient will have a repeat examination of bone marrow after the induction chemotherapy. So after the chemotherapy, of course, the lymphoblast will die. The marrow will regenerate and the hematopoietic elements will now repopulate the marrow. So you will start seeing the marrow and the normal hematopoietic elements like erythroid precursors, mature lymphocytes, and also this something called hematogones. This hematogon is actually normal B lymphocyte precursors that present in the marrow. They look like blasts, but they are just a normal component of the marrow. So during our cytomorphological examination using microscope, we will count about 500 cells per slide. So we will say the patient in morphological remission if the blast is less than 5% in the marrow. Whether this 5% is a leukemic blast or hematogones, we can't reliably tell in this cytomorphological assessment. So this is what we conventionally do previously. So MRD refers to, what is MRD? So MRD refers to the presence of residual leukemic blasts that are undetectable using the conventional cytomorphological assessment using microscope. So the concept of MRD is that if you have the likelihood of disease relapse is related to the amount of residual tumor cells at the end at certain time point of the chemotherapy. So let's say after the induction chemo, and if you still have blood cells detected using microscope, we call it disease persistent. If we cannot detect the blood cells under microscope, but MRD, you can detect residual disease with the flow cytometry or PCR method. We call it MRD positive. Patients are likely to get relapse very early if the MRD burden is high. late relapse if the MRD burden is low. And last but not least, if there is no MRD detected at the end of induction chemotherapy or before the consolidation, the likelihood of the patient not to have any relapse is very high. So this is the concept of MRD. An ideal technique to detect the MRD, of course, you must have a good sensitivity of at least 10 to the power of -4 to 10 power of -6, meaning that you can detect one malignant cell in 10,000 to 1 million of normal cells. So this is how deep we are going to analyze the sample. So the traditional microscope will allow you to examine around 1,000 cells only. And this MRD technique should be able to reliably distinguish the malignant cells from the normal regenerating marrow cells. They should track on a stable leukemic marker so that this marker will not lose during the chemotherapy and give you a false negativity. Then, of course, we want this assay to be reproducible, have a rapid turnaround time, and of course, quantifiable, because you know the MRD low and high MRD burden will give you a different prognosis as well. So if I have to use an analogy to describe MRD, this is like finding a needle in a haystack in terms of the depth of the analysis. And it also like finding where is Waldo. So just like this game is that you need to spot where is the Waldo among the many normal counterparts because of its distinctive features. So this is about MRD. So why we need to do MRD? MRD is the most powerful prognostic factor in acute leukemia. So this chart, if we do, usually we do MRD at 2 time points. One is post-induction chemotherapy and another time point before the consolidation chemo. So based on this MRD result of these 2 time points, we can divide our patient into a low-risk group where the MRD is not detected at all, or high-risk group if the MRD is detected at one of these time points with a high burden more than 0.01%. So intermediate risk group is something in between them. So if you follow this chart, you could see that the MRD negativity, the group with a negative MRD, the percentage of disease relapse in 5 years is less than 2%, whereas the high-risk group with a positive MRD more than 0.01% at any time point, the relapse risk in 5 years' time is almost as high as 80%. So MRD allows the early recognition of disease persistence, and it also allows personalized medicine, whereby the high-risk patient, you can assign them to a more intensive chemotherapy arms, and those with a low-risk patient that unlikely to relapse, you can give them a lower you can give them a lighter chemo, sparing them from the unnecessary treatment toxicity. So how we detect MRD? As mentioned, we can detect them using flow cytometry, and PCR method somehow being regarded as a gold standard. So you can either do a qPCR or digital PCR if the patient, the leukemia has any recurrent genetic fusion like BCR-ABL, MLL rearrangement. You can detect this fusion mRNA transcript using digital PCR. Or you can, in terms of lymphoblastic leukemia, they will have a very signature, unique immunoglobulin VDJ rearrangement. At diagnosis, you identify this unique rearrangement. You could design the primer so that in the next check marrow, you can use this primer to PCR amplify this Ig gene, immunoglobulin gene, to look for if the similar signature unique VDJ recombination is still present or not. So for this allele-specific qPCR, you will need patient-specific primer. And now with the advancement of technology, people are using NGS. where they can, you don't need a patient-specific primer because they could massively, parallel massive, what we call it, they can massively detect a massive array of VDJ rearrangement combination. So you don't need a patient-specific primer. So this table is to compare the pros and cons of each technique. So as already mentioned, not all ALL had recurrent genetic fusion. So qPCR for fusion genes only applicable to 40% of the cases. Patient-specific ASO qPCR is widely applicable to almost 95% of the case. It is sensitive. They has a standardized guideline in Europe. However, we didn't use in our lab because it's very time consuming. It's expensive because each different individual patient will need a different set of primers. And so you need extensive experience and labor to do this. NGS, we have commercial kits available, we call ClonoSet. However, is expensive. You may need to batch testing, so that probably you need to wait about 16 to 20 samples. Only you will run once for the NGS, and that will make the turnaround time around 2 months or 3 months. If the workload is not high, then this is too late for us to have to change the chemotherapy strategy. So this is the paper published by the Euroflow Consortium about standardization of flow cytometry MRD detection. So what they do is that they show that if we run the flow analysis for MRD detection with 4 million cells, the concordance rate of the flow cytometer and the gold standard PCR is as high as 93%. So this shows that this paper with the panel design, it shows that the flow cytometry is as sensitive as the PCR and with good concordant rate. So we adopt their panel, and this is how we do in our lab also. So before I go in further to describe our panel design in our lab, I just want to have a brief introduction about flow cytometry. The principle of flow cytometry is that we know that on a particular cell, for in these instances, I give example of a B cells. They have a lot of surface protein, like CD19, CD20, depends on the maturation status. So we want to know if these cells have any protein. We will put a complementary antibody that conjugated with a fluorochrome. So then this antibody antigen suspension will be submitted to the flow cytometer, and then we interrogate one cell at one time with the laser. So at the interrogation point, the laser will excite the fluorochromes, and each different fluorochromes will have a different emission wavelength. So the different wavelength emission wavelength will be detected with a different filter. So all these light signals will then converted into an electronic signal in the photomultiplier tube PMT. And these electronic signals will be amplified and convert into the digital data for us to analyze in the software. So this is just the raw data that we obtain after we run after we do the acquisition in the flow cytometer. So one dot represents one cells. So this is how a 4 million cells will look like in the software. So before I go in further, I just want to introduce you our 2 tubes, 8 color panels, flow cytometry MRD detection for B-cell ALL in our lab. So our analysis strategy is is only 2. We identify them, the leukemic blast, because we can identify them as a leukemic blast because they are different from normal, or the leukemic blast express leukemic associated immunophenotype, LAIP. So this is the example of the analysis in our software. So in these instances, we are interested in the B cells. So if the cellular event is at this quadrant, so meaning they are positive for CD19, this axis. If the cellular event is in this quadrant, means they are positive for CD20 or anything that in the y-axis. So if they are in this quadrant, means they are positive for both 34 and CD10. If they are negative in this quadrant, means they are negative for both chroma. So for B cell ALL, we focus on the CD19 positive cells. So we highlight all the CD19 positive B cells. Immediately, you can see an range of B cells with different maturation status. So this is the normal maturation pattern, where as the cells getting more and more mature, like a mature B, they will acquire CD20. They will start losing the CD10. Similarly, they will start losing the CD34, reduce the expression of CD38 and 81. So this is how a normal B cells mature in the marrow with different level of expression of the markers. And then we have 4-LAIP, leukemic associated immunophenotype, 66C, CD123, 73, 304. So in normal situation, all these B cells should not express CD66C, 123, 73, or CD304, regardless of their maturation stage. So if you have a B cells that express any of these four markers, it will be recognized as LAIP. So as I mentioned, we acquire 4 million cells. So the lower limit of detection, our limit of detection is 0.0005%, and lower limit of quantification is 0.00125%. So this describes the sensitivity level of our assay. So this is an example of a positive MRD case with high burden, 1.8%. I say our analysis strategy is different from normal expression of leukemic-associated immunophenotype, right? So again, we focus on the CD19 positive B cells. We have residual hematogons here. Stage 1, the most immature hematogons. Stage 2, but I think we have a rather minimal mature B cells here, almost not there. But we have one red population, these are the blood cells. They have their expression level of the maturation marker are different from the normal hematogons. So you can see they are expressing CD34, the immature marker, very bright CD10 than the usual hematogons would express. Yet, when the 34 is so bright, they already express CD20. So this is what we call it asynchronous maturation pattern. So you know that this is something abnormal already. Then of course they have a lower level of CD81 that we would expect if they are CD34 positive. We expect them to be this high level of a CD81, but yet they are downregulated like a mature B. So this asynchronous maturation pattern gives you confidence that this is an abnormal lymphoblast. They are not the healthy hematogons. Then of course, they also express the leukemic-associated immunophenotype 73, 304, 66C, 123. So we are very confident this is a clear-cut case of MRD detected high burden, 1.8%. Not only that we can detect something as high, so just now the case is only 1.8%. The total blast count in the marrow is just 2%. So although we say conventionally, we call it morphological remission under microscope. If the blast is less than 5%, you can tell that even with 5%, 1% of it could be the leukemic blast. So now this case, what I want to show you is a lower burden of the MRD of 0.064%. So again, we focus on the CD19 positive B cells. You know that there are residual stage 1, stage 2, and mature B stage 1, stage 2 hematogones and mature B cells. But you also can see one population of B lymphoblasts that are different from normal, where they have positive for CD34, very bright CD10, brighter than the normal hematogones. When the 34 is still so bright, they already express CD20, asynchronous maturation, and then they have a reduced expression of 81 and CD38 that we would expect in a stage 1 hematogones at lower expression than a normal hematogones would be. And in this case, we also had LAIP here, CD73 and 304. So with the combination of CD66C, CD123, 73, 304, which these are the LAIP that would be present in about 70% of the lymphoblasts. So with combination of these LAIP markers and the maturation pattern, we are confident that our flow assay could detect as 93% concordant rate with our PCR method. However, there are limitations to the flow cytometry. So like I say, these LAIP markers only can be found in 70%. So there are 30% of the B lymphoblasts did not express any of these LAIP. And post-steroid because the patient also at the same time receives steroids during their induction chemotherapy, and steroid is known to make the lymphoblast maturation marker expression. Should I say? Okay, so because of the steroids, the lymphoblast expression for the CD20, 34, 38, 81 will be altered compared to their diagnosis. So they tend to shift to a more maturing level of expression. So there are chances that these 30% of the cases that didn't express any of the LAIP markers also have a shift in the immunophenotype maturation expression, so that they are going as they are like merging to the maturation pattern. So if this lymphoblast expression level merged with the maturation pathway and they didn't express any of these LAIP markers, and these are the potential source of false negative result in the flow. We can't detect them even they are present. So that's one limitation. Second thing is we have a lot of this targeted immunotherapy. So this case, what I want to show you here is the case that possibly pose blinatumomab. So blinatumomab is a bispecific engager, T-cell engager bites. So what they do is they have a target binding site for CD19 to bind the lymphoblasts. They have also a binding site of CD3 to bring this lymphoblast to a T cells, to a normal T cell for tumor lysis. So the lymphoblasts are quite clever. They could evade this immune modulation. They can escape this by down-regulating the CD19 expression. So just now, when I say showing the case, we say we will focus only on the CD19 positive B cells. So in cases with blinatumomab treatment, we can no longer rely on CD19 alone because they are almost almost negative for CD19. But if you examine all the background cells, you will notice there is a population of blast cells that are very bright CD10. They are immature because they are still expressing CD34. But when the 34 is this bright, the CD81, 38 have been down-regulated. So there's some form of maturation asynchrony. So we know that these are the abnormal blasts, but we couldn't prove that whether these are the B lymphoblasts or not. So with that, we need to throw in the third panel with more B cell markers. So the CD22 and 24 is also a quite specific B cell markers, but they, unlike CD19, they also can be found in the granulocytes. So we need to prove that these population are positive for the B cell marker CD22, 24, but they did not express any CD66B that would expressed by the granulocytes, just to prove that these are the true B cells. So of course, they also, like the previous panel, they have a very bright CD10. When the 34 is still positive, they already have a down-regulated CD38. So this shows that one of the main challenge in flow cytometry is that post-treatment, you will have a phenotypic shift and down-regulation of even the gating marker CD19 if you use targeted therapy. So in short, MRD in leukemia is the cornerstone of precision medicine. Flow cytometry is fast, robust, and highly sensitive, and even comparable to PCR. But phenotypic shift post-treatment remains a challenge. We still need continuous panel updates. So with that, I thank you for your attention.
Thank you, Dr. Lai, for the comprehensive and insightful presentation. You have clearly demonstrated how measurable residual disease, represented by very small numbers of cells, carries a significant implication for risk stratification and therapeutic decision and patient outcome. So the establishment of flow cytometry based MRD service in our center marks an important step forward in enhancing the quality of precision of our hematology practice. So I hope this session has provided a valuable insights for both clinicians and lab professionals in integrating MRD into routine patient management. So thank you to everyone for your attention. So we will now open the floor for question and discussion. So we have one note here. Thanks, Dr. Lai, for a very interesting insight of MRD. For those high burden MRD, those population that hide CD34 and those left behind after chemotherapy, do you know what this population is? Do they have any hematopoietic stem cell markers or any high tumor initiating capability, especially if they don't have much of maturation markers? Thanks. So, Dr. Lai?
Yeah, so I think what you refer, I think what I understand from the question is that in probably not so much in lymphoblasts, ALL cases, but we do notice a case of leukemic stem cells in AML. So these leukemic stem cells tends to be very, how to say, at the low-lying level among the bone marrow. They are resistant to chemotherapy. They have a regenerating capacity. So the detection of the leukemic stem cells in AML actually is a point for poor prognosis. But the study of leukemic stem cells in BAL is not that extensive. We are not sure whether they also have a similar role in AML. Yeah, I hope I answer your question, Dr. Sally.
Thank you, Dr. Selvi, for your question. I think we have no more question from the floor. So for that, it's my pleasure to welcome our next speaker, Dr. Rama Krishna, Senior Lecturer from Department of Social and Preventive Medicine, to proceed. Thank you. Thank you, everyone.
Thank you.